Hello wonderful students, myself Dr. Maddineni Srinivas. In this video we are going to cover one theory question which was asked in the medicine paper from dermatology subject. So the question is Reiters syndrome, but you better remember it as reactive arthritis. So Reiters syndrome is not used nowadays much. So it is basically a triad of what are the three components? You can easily remember that with the help of can't see, can't pee and can't climb a tree. So the patient is going to have arthritis, urethritis and conjunctivitis. So these three are very important for you to remember: arthritis, urethritis and conjunctivitis. After an infection which could be in the gastrointestinal tract or it could be in the genitourinary system. So what is the exact etiology? What are the causative organisms you are going to see? But before that, remember it is going to be associated with HLA-B27. Very important. So if you write these important points in the exam, theory exam, you are going to get good marks. So in the gastrointestinal tract, what are the infections in the bacteria? Shigella, Salmonella, Campylobacter erisina. These are the important infections. And in the genitourinary tract, the infections could be Chlamydia trachomatis and Neisseria gonorrhea. And HLA-B27 is associated almost 63 to 90% of the patients who have the reactive arthritis. So what will be the clinical features? You know already the triad: can't see, can't pee and can't climb a tree. So this is going to mainly affect the young men and it will develop 1 to 3 weeks after the genital or the bowel infection. And arthritis is going to be oligoarthritis, that is, it is not going to be bilaterally symmetrical and less than 5 joints will be affected, and most importantly the large joints of the lower limbs are the important ones which are affected. The patients, because of the arthritis, there can be mild dysuria or minimal symptoms may be present, and conjunctivitis may present as mild redness of the eye or little bit of irritation. So extra articular manifestations, the patients can have Achilles tendonitis, plantar fasciitis. So there can be heel pain. And in the dermatology, you can see there are going to be circular areas present over the glans penis. These are called as circinate balanitis, which are absolutely painless erosions. And in the skin over the soles, we can see that the skin is going to be thickened, and we call this thickened skin over the sole as keratoderma blenoragicum. Keratoderma blenoragicum. In the nails, we can see there can be destruction of the nails called as nail dystrophy, and in the oral cavity there can be ulcers. And the patients may have the constitutional symptoms of fever, malaise, weight loss and so on. So investigations, what can we do? So we have to identify any inflammatory markers, ESR, CRP, we can see that, and their patients may have anemia. And if you do a synovial fluid analysis to identify any infectious organisms, so it is going to be sterile, because it is not the infection of the joints, but it is due to the reaction to the infectious agent, because of which there is going to be this arthritis here. So we are going to see the Reiters cells, which are the giant macrophages present inside the synovial fluid. Microbiological tests. So urine culture may detect the chlamydia or Neisseria. Stool culture, it is going to only rarely show the organisms, because by the time arthritis is clinically kicked in, the microorganisms may not be seen in the stool culture. Serology may help because the antibodies may be present, because it is seen 1 to 3 weeks after the infection. If you remember, I have told you it is 1 to 3 weeks after the genital or bowel infection. So only antibodies may be helpful in the identification or the finding out the diagnosis. Coming to the markers, remember this is going to be negative, this condition, reactive arthritis, negative for rheumatoid factor and also ANA. This is going to help in differentiating from the RA, rheumatoid arthritis. So if you see the X-ray findings, early X-ray may be absolutely normal, but later on the joint spaces may be narrowed, and also there can be periosteosis, the bony thickening can be noted, erosions and sacroiliitis, these changes can be noted in the radiology. Coming to the management, so The first line of the treatment is going to be with non-steroidal anti-inflammatory drugs, indomethacin, ibuprofen, and steroids. We can directly inject the steroids into the joint, intra-articular injections, and systemic steroids may be used if the eye involvement is very severe, that is anterior uveitis. DMARDs, disease modifying anti-rheumatic drugs like methotrexate, azathioprine, and sulfasalazine may also be used for the chronic arthritis. Antibiotics are used only if there is an active infection by the time we diagnose reactive arthritis. For chlamydia urethritis, we can give doxycycline. So to conclude, Reiters syndrome, better called as reactive arthritis, it is a self-limiting condition but can become chronic at times, and early diagnosis and appropriate treatment help prevent long-term joint damage and the disability. So I hope this video was helpful. If so, please do hit that like button and share this among your friends and comment if you have any doubts. Do subscribe to this channel. All the very best. Happy learning. Sarvam Sri Krishna Arpanam Sarvejana Sukhano Bhavantu. Bye bye.